Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
A big thanks to Laura Avianeta Cruz for joining us. Laura is a licensed social worker and program manager at Alaska Native Epidemiology Center. She has a big focus on relationship abuse, including domestic violence and sexual abuse, and has done a lot of work supporting providers in that arena and creating resources, and we're very lucky to have her joining us today.
Great, thank you. So my talk is part one of a two-part talk. I was fortunate enough to be invited back on April 2nd for the second part of the talk about kind of what to do. So this first part is concentrating on the relationship between relationship abuse and sexual violence and HIV and STIs. I wanted to give credit that some of the images and content are created in part by Futures Without Violence and the Alaska Family Violence Prevention Project, and all of the photos that are not that don't have a copyright are from them. The learning objectives are to describe how intimate partner violence and sexual violence impact risk for HIV and STIs, and to describe how intimate partner violence and sexual violence impact the health of patients who are positive for an STI or HIV. The second part of the training on April 2nd will address the third objective, which is to reduce risks and improve the response to patients. So we'll start with this first objective about the relationship between violence and HIV risk. So when we talk about intimate partner violence or domestic violence, what are we talking about? And I'll just say there are some distinctions between the terms, but I'll kind of use them interchangeably. Domestic violence is a little broader, at least in Alaska statute. Not only intimate partners, but ex-intimate partners and relatives and so on. But what we're talking about is a pattern of coercive and controlling behaviors. So this can include what people often think about in terms of physical violence, but it is much broader than that. The range of possible ways that a partner can coerce and control and threaten an intimate partner is very broad. The point of these behaviors is to maintain power and control, to intimidate and control the victim. And so this can include, as I said, physical violence, hitting, pushing, slapping, choking or strangulation, etc. But it also includes many forms of emotional or psychological aggression, threatening a partner, humiliating them, controlling them, and isolating them. These are some of the most commonly used and important forms of abuse to understand, especially isolation, because it's what keeps a partner away from the support networks that would enable them to get help or enable them to understand that what's happening to them is not their fault and that it's wrong. By isolating them from their support networks, it's harder for them to leave. And stalking, of course, is another. And it also includes, and this is often not thought about as a form of domestic violence, but sexual violence, which can include forced sex, sexual assault, but also coercive and humiliating sex. A partner may want to engage sexually, but not want to in painful or humiliating ways. And it can also include control of reproduction or reproductive health or sexual health. And so that's what we'll talk about next. I want to go in a little bit more into a definition of sexual violence because I find that a lot of our patients, a lot of people in the general public don't know what constitutes sexual violence. And our cultural norms about it often perpetuate the idea that sexual coercion is normal. And so I like to define for people sexual violence as any type of sexual contact, whether it's kissing or groping or penetration, without consent. And so the key here is what is consent, and finding a way to communicate consent to people in a way that they understand and can grasp. This is a panel from our teen card, the gender-neutral teen card that we created for Alaska. And I share this because it's an easy way to communicate consent. So we go through consent has to mean that people are able to consent, that they're aware, conscious, sober, that we're not taking advantage of somebody who's blacked out or asleep or drunk, etc. For teens, of course, or for minors, this means that close in age, that we don't have power inequalities based on age or authority. And of course, the power inequalities based on authority can be for adults as well. And then that we consent. That consent is an enthusiastic, emphatic yes, a verbal yes. It's not something that's implied. And so we offer to teens with this card, some examples of how to obtain consent, but really stress that it is a verbal, enthusiastic agreement. It's not coerced, it's not pressured, and that it's specific, so you can consent to one thing and not consent to another, and that you can change your mind in the middle of it, and that has to be respected. So I share this with you as a way to communicating that to patients. So one form of power and control behaviors that is unfortunately far more common than I think originally thought is reproductive coercion, and that's any coercion around reproduction. So this may include explicitly attempting to impregnate a partner against her wishes or controlling the outcomes of a pregnancy. So it's not necessarily that all reproductive coercion is about pregnancy, but it's about controlling someone's reproductive health, controlling a woman's reproductive health. And so it may mean forcing her to have unprotected sex, but then forcing her to terminate the pregnancy, or threatening her if she does terminate the pregnancy. Some of these coercion can be, I will leave you if you don't get pregnant. I'll go get someone else pregnant if you don't get pregnant. There are many ways that this coercion happens, and then coercion around abortions, and then coercing a partner to have unprotected sex. So refusing to use condoms, saying, if you want to use condoms, it means that you are cheating on me. Using coercive tactics to not protect the partner, or making the partner feel threatened if they even bring up the conversation of condoms. And then interfering with birth control methods. So this can be poking holes in condoms, taking them off during intercourse, throwing birth control pills away, hiding birth control pills, not allowing them to go back to the clinic for depot shots, pulling out IUDs. So any form of coercion, of tampering with birth control. And often the patient may not know that the partner is doing that on purpose. They may think that they're being silly, or it may annoy them, but not realize that that's a power and control tactic. And so this is some education we can do. Unsurprisingly, because this is a power control tactic, we see that there's a relationship between abusive relationships and unwanted and teen pregnancies. And so this study found that adolescent girls in abusive relationships were 6 times more likely to become pregnant than unabused girls. Likewise, the same risk factors for pregnancy are risk factors for sexually transmitted infections. In this study, in an urban clinic of about 450 adolescent girls, found that nearly half who were tested for STIs or HIV had experienced physical and or sexual intimate partner violence. This relationship also seems to exist with men. A lot of this data is for girls and women only, but there is some data available for men, and I'm attempting to share as much of that as possible. So this study of 56 HIV-positive men found that the majority, 73%, reported lifetime intimate partner violence, and 20% reported it from a current partner. Intimate partner violence is linked with risk behaviors. And so women who experience past or current IPV are more likely to have, according to the study of 800 women presenting to emergency departments, more likely to have multiple sexual partners, have a past or current sexually transmitted infection, have a partner with known HIV risk factors, including intravenous drug use, report inconsistent or non-use of condoms, and inject drugs. So the relationship between these risk factors and intimate partner violence is complex. It's not only one thing, but we do know that when there's intimate partner violence, there's a lack of control of sexual decision making. So a lot of the things that we consider the patient taking risks, or the patient may not have control over those risks. And so what we know is that knowledge isn't enough. Knowledge about risk and what to do and what not to do is not enough to protect people who are in abusive relationships. This study found, this is a study of 715 women, that under high levels of fear of abuse, women who had high knowledge of sexually transmitted infections were still more likely to use condoms inconsistently than women who had low knowledge but were not fearful. And so the knowledge alone didn't protect them if they were fearful in their relationships. So similarly, this study of teen girls found that girls who were experiencing dating violence were 2.8 times more likely to be afraid, to fear the consequences of negotiating condom use. So it may be that their partner refuses to use condoms, or maybe that they're too afraid to even bring it up with their partner. Now I want to link this back to ACEs, because a lot of these risks I'm describing are from contemporary abuse in a relationship, whether it's teenagers or adults. But also a lot of these risk factors come from childhood as well. And often having trauma in childhood puts someone more at risk of being in an abusive relationship in adolescence and adulthood. And so these risks are kind of meshed together. And I imagine most of you are familiar with the Adverse Childhood Experiences study, but it's a study of 17,400 adults at Kaiser Permanente in San Diego. And it asked about 10 different adverse childhood experiences: physical, emotional, sexual abuse, different types of household dysfunction, and then looked at different health outcomes if people had experienced these ACEs. And so the number on the bottom of the graph is the number of different adverse childhood experiences that they had experienced before age 18. And what we see is a strong dose-response relationship. The more ACEs, the higher the likelihood of a whole number of poor health outcomes, but including these risk factors for HIV and STIs. So we see that the higher the ACE score, the more ACEs someone had, the higher the likelihood of them having over 50 sexual partners in their life. And we see that same really very strong graded relationship with intravenous drug use. In fact, in a attributable risk fraction, they found that 78% of intravenous drug use could be attributed to adverse childhood experiences, to trauma in their childhood. And so these risks are interrelated. And for children, exposure to domestic violence is one of those ACEs. And so if we are doing a good job of intervening with patients who are experiencing violence, we are potentially protecting their children from a lot of these long-term health outcomes. So next we'll move on to how intimate partner violence and sexual violence impacts the health of patients who are positive for an STI or HIV. And I want to share with you this quote that research shows us that violence is both a significant cause and significant consequence of HIV infection among women. So to illustrate this study of 310 HIV positive women found that almost half had experienced abuse after being diagnosed with HIV, and 4% experienced abuse as a direct consequence of disclosing their HIV status. And so what this may mean is that point of disclosure is something you want to do some safety planning around, because it could be a potentially dangerous time. And this study, the same study of 56 HIV positive men that I mentioned earlier, found that the majority had experienced it, and 29% of those abused felt that the abuse was related to their HIV status. So they felt that their HIV status made them more vulnerable to abuse. And in fact, this is a systematic review of all published studies about look at the intersection of violence, of intimate partner violence and HIV. And what this review found is that women who are HIV positive experience more severe and frequent abuse compared to non-HIV negative women. So even when both are experiencing abuse, the HIV positive women are experiencing more abuse and more frequent abuse. And in fact, there are some very serious consequences for HIV positive women who are experiencing abuse. This is based on a study of 304 HIV positive women from HIV clinics. And it found that HIV positive women who were experiencing intimate partner violence were more likely to report inconsistent condom abuse stemming from their request for condom use, so as I had mentioned earlier, and pregnancy. This study, which came from focus groups with HIV positive patients, found that intimate partner violence is a major barrier for obtaining regular care, for being able to go back to the clinic, for being able to adhere to treatment regimens. That can be because of just power and control tactics, watching where the patient drives, monitoring their mileage on their car, not allowing them to go out of the house, have access to transportation or money, etc. But also, a form of abuse can be directly interfering with someone's medications or treatment. And so some of the implications for HIV programs are that partner notification may be dangerous for clients. And so if that's a routine part of practice, putting in some safety measures there, asking questions to determine whether the patient does feel like it'll be dangerous to notify their partner, and connecting them with a victim advocate to do some safety planning around that. Or, of course, whenever possible, doing anonymous partner notification. It's also important to remember that clients may not be able to negotiate safe sex with an abusive partner. And so knowledge, saying, okay, this is what you should do, may not be enough, that safety planning piece has to be a part of it. And also it's important to recognize that intimate partner violence may be what the client considers the most immediate threat to their health, rather than their STI or their HIV. And so understanding where the client is at in terms of understanding their risks and their goals. And then recognizing that if they're in an abusive relationship, that can pose a barrier to treatment. And so thinking about treatment regimens that may be less able to be interfered with by an abusive partner. And so part 2 on April 2nd will address kind of the what to do. What is the safety card approach? What are some evidence-based strategies to reduce risk for patients?